Hello, and welcome to the Project Good podcast. I'm your host, Anne-Marie Hilton. Project Good is a social impact podcast interviewing experts and advocates about the pressing problems that we face globally and hearing how they suggest we move forward in the future. The Project Good podcast is brought to you by Project Good Work. The goal of this podcast is to inspire people and organizations to develop a mindset that can move others to positive action regarding the complex social issues facing people and the planet. Globally, the average lifespan has increased in most countries due to the rise in technology, increased globalization of resources, and the decrease in physical labor. While having a longer life and more time has its benefits, the longer we stay on the planet, the more resources are required to maintain a healthy, functioning, and economically viable life in society. As more people age, keeping everyone healthy becomes a challenge not faced before. The obvious challenges of aging are currently being heightened by fewer people entering the medical field, a declining young population in developing countries, questionable global economic futures, the rising cost of healthcare, the inability to provide universal access to the latest medical care, increases in mental illnesses, and the lack of the ability to control global diseases. Keeping the population healthy and providing care is of utmost importance, but these barriers must be closely examined and eliminated or controlled for us to thrive. Today, I have the pleasure of interviewing Dr. Mark David Monk, a Canadian-American who has emerged as a prominent figure in healthcare, driving change in emergency medicine and healthcare management across the U.S. and internationally. His career began as an emergency medicine professor and as the medical director of Qatar's National Ambulance Service. Advancing to executive roles, he served as chief medical officer for an elite physicians group and as the regional president for an international division of a leading American healthcare system. Raised in Switzerland and Canada, Dr. Monk's educational path led him to earn a bachelor's in philosophy and religion from Colgate University. He then attained an MPH in international health from Boston University. His medical training was completed at Jefferson Medical College in Philadelphia, followed by an emergency medicine residency and international health fellowship at the University of Pittsburgh. He holds a diploma in tropical medicine from Peru's Goras program and master's in healthcare management from Harvard University. Through his time as a medical professional, Dr. Monk has been known as an innovator who does not want to lose touch with the reason he got into medicine, to help people. Let's get into the interview. The crisis in Western healthcare encompasses several interconnected issues that vary by country, but often include cost. Healthcare expenses continue to rise, straining budgets for individuals, families, and governments. This includes the cost of insurance premiums, medical procedures, medications, and long-term care. Secondly, access. Not everyone has access to affordable healthcare. This can be due to a lack of insurance coverage and limited availability for healthcare facilities and professionals in rural areas. Another thing is quality and safety. While Western healthcare systems often provide high-quality care, there are still concerns about patient safety. Then there's chronic disease management. Western societies face a growing burden of chronic diseases such as diabetes, heart disease, and obesity. Continuously, mental health issues, including depression, anxiety, and substance abuse, are significant concerns in Western society. And rounding it out, there's healthcare inequalities. Disparities in healthcare outcomes persist among different demographic groups, including racial and ethnic minorities, low-income individuals, and rural populations. Dr. Mark Monk is a writer and healthcare executive who, according to the advisory board, a U.S. healthcare consultancy, has a reputation as an innovator. Dr. Monk is recognized as a thought leader in the area of value-based, consumer-facing healthcare and global health. Dr. Monk serves as a chief medical officer for clinicals and retail pharmacy at CVS Health. Prior to joining CVS, Monk was the chief medical officer at Elora Health, a Boston-based primary company that has been highlighted by the New York Times and Wall Street Journal for its innovation and effective care model. And Business Insider in 2018 noted Monk led the healthcare system's care model and care delivery at practices across 7 states. During his tenure, Monk helped restructure a lawyer's health model of care, including integrating behavioral health. His work resulted in an improved health quality scores across the board. Welcome, Dr. Monk.
Anne-Marie, thanks for having me.
Thank you. I am excited to talk about this conversation because, of course, who doesn't want to worry about their health?
Exactly right.
Right? It's the number one thing because, as they say, if you don't have health, you don't have anything.
No, that's exactly right.
Yes. But before we jump in and I start, digging into your brain, I was a little bit intrigued because, every time, in my past, that when somebody decides that they're going to go into the medical field, most people study, go to their undergrad and study biology or maybe kinesiology or something of that sort. And so when I saw that you started your undergrad, doing something different, it kind of intrigued me. Like, how did you go from like philosophy and religion to, becoming a doctor? I would think that you would end up being like a pastor or something.
Yeah, it's kind of an untraditional track for sure. I ended up studying those subjects in university because I thought they were just fascinating. I mean, they were, for me, really the big questions about how you should live your life and what was valuable and how you should sort of assess the world around you, maybe. And I really loved the courses that I took in undergrad, but fortuitously, I went to college in a small town in upstate New York that had a volunteer fire service and a volunteer ambulance service. And just out of chance, I got pulled in as a volunteer and started spending my evenings and weekends doing shifts with the ambulance and fire service, seeing patients and becoming trained as a medic and a firefighter. And I realized that by the time I got to the end of my 4 years that I had really been taken with the work that I was doing in that environment, really because I think it was a practical application of the concepts that I was learning maybe more theoretically in college. And so I made a late decision to go to medical school. I mean, I really had no preparation, quite honestly, to go. I had done no science classes. I was really fully unprepared for it. So I ended up going back to do some science, and a couple years later went to medical school, and I was, quite a few years older than my classmates.
Okay. Yes, that's interesting. I'm making the assumption that, because of what you studied in undergrad, you already had a heart for people, right? And kind of digging into their why for existence. I'm making that assumption, of course, because, when I think about philosophy.
Mm-hmm. Yeah, no, you're right. And in fact, I thought I was going to be a journalist. I've always been really curious about people and how they make decisions and how they live their lives and really just how they navigate. And I thought I would approach that from the perspective of being a journalist, and it didn't turn out to be that way. Although as you note, I came back to writing much later in my career and wrote a book. But I realized that there was something very immediate about being a doctor and having access to really the innermost stories of people's lives, and to me that was very powerful.
Very cool. And, I was reading actually your book, Urgent Calls from Distant Places. Yes, Dr. Monk has written this very touching and moving book for those people who are, similar to me, that I like to jump in, not only, of course, stories, but I like stories that kind of have sometimes a National Geographic tinge to them. Yep. And so I loved it. So the book is called Urgent Calls from Distant Places, an emergency doctor's notes about life and death on the frontiers of East Africa. So, of course, it has adventure. It has the Indiana Jones feel that I love. Of going out to places not known, and finding yourself, essentially. So I guess when we start to dive into, I want to kind of get people to understand your heart. That's why I'm going here. I guess give us kind of the setup of what got you to East Africa.
Yeah. So the story, I think, really started my career in a fairly traditional way. I went to medical school. I did residency training. I did fellowship training. And it was a lot of years of sacrifice, and I would say I didn't necessarily have an aptitude for the hard science, and so it was a lot of work, I think, to make it through and to graduate and to become a practicing doctor. And I realized one day that I was seeing patients in a city hospital in Pittsburgh, and I remember looking around the emergency department and thinking to myself, I mean, surely this can't be it, right? Like, after all of these years of work and training to become a doctor and setting your heart on this one thing, I had finally achieved what I had set out to do, and it wasn't what I had hoped at the end of the day. I realized that the system was so fundamentally broken and dysfunctional that the kind of medicine I was forced to practice wasn't what I had aspired to practice when I first set out, that it was really reduced into a series of 3 or 5 minute visits with patients and constantly having to triage who was coming in and cutting corners and really trying to move patients through the system because the crowding and congestion was so acute and the waiting room never emptied out. And it was this treadmill of medicine that I realized I was going to be spending the next 20, 30 years of my life performing if I didn't take a chance to step back and reevaluate what I was doing and what was important to me. And I would say it was almost a moment of despondency, right? And like maybe you've been in these positions where you set your heart on something and work for years and years to achieve it, and it didn't turn out to be what you thought it was going to be. And I realized at the time it was a call for me to step back and reevaluate what I wanted to do with myself and with my career. And as I say in the book, it was really kind of a good piece of luck. I ended up sending a cold email to Africa. There was an organization there called AMREF, which ran a service called the Flying Doctor Service. It was originally doctors, a bunch of Western doctors who founded this thing in 1953, and they were flying Cessnas across East Africa to provide clinics and surgeries and those sorts of things. And flying doctors had really evolved into the most advanced air ambulance service in Africa over a period of years. And I sent them a cold email and I said, listen, I'm a well-trained emergency physician. I've got a lot of air ambulance experience. Would you be interested in having me for a couple months as a visiting doctor? And it was one of those great pieces of luck. Somebody wrote back a couple days later and said, yeah, absolutely. We actually have an opening in a month or two from now. Would you be interested in coming down and staffing our air ambulance for a couple months? And I said, sure. And so that's how I found myself in Africa. And I was lucky enough to keep a blog at the time. I kept very detailed notes of the countries that we went to. We went actually to 11 different countries in Africa over a period of several months that I was there. And the book that I ended up writing years and years later was a collection of 22 of the most interesting stories from that period. And so, as you say, yeah, there's certainly, Indiana Jones, maybe. There's a lot of interesting medicine there and interesting patients. But the book also, to some extent, is an accounting of my own coming to terms with medicine and with my role as a physician and really with what it was I wanted to do as a human on this time that I had left on Earth, So that's the book.
Yes. And, I think that, you talk about kind of having like this despondence of like, where am I going? What am I doing? I think that's obviously a common thing that happens, and especially in today's world because there's so many choices and directions that you can go. And specifically, looking at the medical field, which is, in and itself, I would say taxing not only from, the knowledge you have to have, but I'll just be honest. It may not sound pretty, but you have to deal with people.
Yeah, you do. Yes, you do. Unless you're a pathologist. I mean, maybe you don't,
Yes. And so, in and itself, we all know how exhausting that can just be, even if you're not. And then when you're dealing with people who are not feeling well, it just, heightens the stress level even more, and the exhaustion level. Because, whether people want to believe it or not, we're all a little bit difficult to deal with at times.
Oh, yes, indeed.
Yes. And so, with this, wonderful experience that you got to kind of step out, and I guess I'm going to say step out and also step in to kind of the reason that you initially became a doctor was to help people. And then being able to kind of step out and say, is this, test yourself, is like this really what I want and really care about still in life. And so when you came back, from Africa and now back to the U.S., what would you say, changed inside of you?
It was always impressed upon us in medical school that there was something very sacred about the doctor-patient relationship, if you were doing it right? I mean, I think in the ideal construct, you establish a very intimate relationship with patients. You hear their inner secrets. You hear what concerns them. You try to interpret what's going on in their bodies. You try to work towards a diagnosis and then collaboratively serve as a partner as patients migrate through the decision-making process towards wellness. And that was something I always believed in, profoundly. To me, that doctor-patient relationship was such an important, sacred thing. And what I was really struck with when I was working in my early years in emergency medicine was how it was so at odds with the system that had evolved in the West, that to my mind, the whole system that we were forced to work in was this morass kind of on one level, economic greed, on the other level, high levels of bureaucracy and dysfunction, on the other level, highly conflicted kind of political deal-making. And ultimately what happens in emergency medicine is that all of the dysfunctions in the Western healthcare system, no matter where they are, like whether they're political, whether they involve a hospital, whether they involve long-term care as an example, all of the dysfunction ultimately trickles down to the emergency department because it's kind of the bottom of the funnel, and it's the only place in the system where the doors are continuously open. And so you have no way to control flow into the system. You have no way to control which patients come to see you. You have no way to control who has access and who doesn't have access. Everybody just comes, and that's terrific. But it creates this enormous strain on the people who are working within that system, where they're constantly torn between what they train to do, what they aspire to do, and the circumstances with which they're forced to deal with. And it's this terrible tension, and it's really the basis, I would say, and I'm sure we'll talk about this a bit more, of this concept of burnout in Western medicine, where the doctors and nurses are leaving the profession in droves. To my mind, in large part because of this terrible conflict that's being created between their inner compass and moral values in opposition to the system in which they're forced to work.
Yes, and so you speak of something that I personally experienced about doctors leaving in groves. I guess you could say fortunately and unfortunately, I gave birth during the pandemic of all times to see medical chaos. That was the time.
Yes. Oh, oof. Yeah.
And the height of it in April 2020 of all times.
Wow.
And all my doctors quit.
Sure.
They gave up. They came up, and one of my doctors ended up with COVID, so couldn't help. And so I saw it firsthand that the burnout doctors were experiencing. Of course, this was a global emergency that nobody could have been prepared for, right? Mm-hmm. So that's an extreme case, but it showed directly the support that was lacking in multiple areas. And what I mean, the tools, well, not as we found out, not all the tools were there, because, they had to choose who gets a respirator and who doesn't and all these things. But also there's the humanistic side that was lost, because, one of my doctors, she told me that, she also has to think about not only her well-being, but she also, we forget that, you have your own families too, that you have to worry about. So there's there's this lack of, I guess, care for the caretakers, which then I saw takes a toll, of course, on the care that's then given to the patient, right?
Mm-hmm. Mm-hmm.
And so, where I'm going with this is that, I know a lot of people these days, if they're really, concerned about their health, are leaning more and more to a holistic approach. And so I wanted you to kind of explain what is this like, I guess, a movement to, and I might be using the wrong word. I use holistic because, I don't know, maybe I'm a little bit hippie. But I guess, what would you say this like new movement, or I guess, I'm sure you've seen it. Maybe, like I said, I'm using the wrong term.
No, I think it's the right term. I would say it's important to recognize when we're talking about medicine that I think what we're describing is really a paradigm of Western medicine that we've become accustomed to. And it's important to remember that around the world, that's not necessarily how people think of medicine or think of wellness, right? The Western medicine paradigm is one that's very much really focused on like the biology, right, of the body, and how disease functions. And how we can use evidence to guide our scientific research and our decision-making and use data. And what we do is really reduce complex ideas in medicine down to their simple parts, right? The atoms and the electrons. And it's all this kind of we call it reductive model. And really, I think we have a tendency in the West when we're dealing with patients and medical issues to try to reduce their symptoms down to a biomedical explanation. And that's the way we were trained, quite honestly, as doctors. And of course, there's enormous scientific validity to thinking about medicine like that. But it's not enough, right? I think what we talk about when we're talking about holistic medicine is incorporating things like people's spiritual beliefs, about including their mental well-being, including, for example, the social circumstances in which they live. So I'll give you an example of this. I worked for several years as the chief medical officer of a company that was doing very high-level, high-touch care for senior patients. And we set up clinics across the United States, mostly in lower economic areas. And we're seeing seniors in these really, really wonderful clinics where patients could come in and stop and have a coffee and meet with their care team. And have a dietitian take them out shopping and have somebody go to their house if there was concerns at home. And, predictably what we saw in that model was that the healthcare measured in any number of ways of those senior patients became dramatically better over time. And it was in many cases, a relatively short 6-month period of time. You could see, for example, somebody's management of diabetes shoot through the roof. It was just so much better. And their blood pressure started to come down. Now, why were the results so impressive in that model? It wasn't necessarily that we were giving more insulin or more blood pressure medicine, but rather I think the model really forced us to think a lot about all of these other aspects of people's lives. So, for example, sometimes people's diabetes was out of control because they were buying the wrong food. They just didn't know what to buy. And we solved that model by sending a dietitian to help them shop once or twice and to explain what was healthy food and what wasn't. And there's, your first big check, right? The second was transportation. So patients couldn't come in to be seen because they couldn't get a ride or the clinic wasn't on the bus stop, or there were any number of other barriers. And so the simple answer to that isn't necessarily more diabetes medicine. The simple answer was that we had a voucher program with Uber, and patients could take a free Uber to come in for their rides, and their diabetes would improve just by virtue of seeing us a bit more regularly. So, another example, patients, we have so many of these great examples, but a patient with with kidney function who was in dialysis for years and would regularly miss dialysis appointments, and the answer when we asked her, why did you miss these dialysis appointments? This was the founder and my boss, Rashika Fernandez-Pule, who told me this story. She said, I'm just bored. These dialysis visits take a long time. I'm there in the chair for hours and hours, several times a week. I've got nothing to do. And when she missed dialysis, she would ultimately end up in the hospital days later, and it would be costly, and she would go to the intensive care unit and all those sorts of things. What was the answer in that case? The answer, frankly, was to buy her an iPod. It was a $150 iPod. They loaded it with her favorite music, and she could then sit in those dialysis appointments and listen to music, and she showed up regularly because she enjoyed listening to her music. Now, I think when we're talking about holistic medicine, it's these simple but thoughtful and sensitive approaches to people's broader person that get the best results. And I think in the Western model, we have this tendency to really just continue to look at the bio model, the biological model of wellness, and that's clearly not enough.
Yes, I was just, the word that came to my mind was like bringing humanity back to healthcare.
Well, that, of course, that was the slogan of the company. Thank you for that. That was our slogan. Yes, it was.
Yes. I actually didn't know the slogan, but there it is.
Mm-hmm. It's so funny. That was the company's slogan. Yes, it was.
Oh, yes. So, one of the things, because, also I realize these are different professions, but then they have a lot of consistencies. And what I mean by that is that they're the same, is I think kind of like medicine and teaching fall on the same spectrum. And what I mean by that is that they have traditions, mm-hmm. right? And so in what ways do you think that tradition is holding us back here in the U.S. In healthcare? Because, here's another thing before you answer the question, because I think, maybe it's a little different now, because young people, they're same, but also very different because of the different things that they've been exposed to. So I don't know, what they're being necessarily taught in schools. I know obviously they have to take the anatomy and physiology because, the body didn't change that much. When we're introducing these, young upcoming doctors, I think that people still have in their mindset, like, what a doctor is in their mind. So how is this tradition that we've set up here, specifically in the U.S., holding us back from having, better health care?
Yeah, like many things, I think there's both wonderful value to tradition, but also some risk involved. And so, I think when you're looking at a profession like medicine that is so potentially risky, right? I think of it in many ways like aviation as an example, that you don't want to be, they say about pilots, right? There are old pilots and there are bold pilots, but there are no old, bold pilots. That there's a necessary risk aversion in professions like medicine and aviation, where we've learned over hundreds or even thousands of years what works and what doesn't work in medicine. And we inculcate the next generation of doctors by teaching them these traditions. There is necessarily, and I think positively, a tradition. There's a tension between this tradition and innovation, as an example, where what you're trying to do on one hand is to make changes that are productive and useful and helpful and evolve the system without killing somebody in the process. And so there's this necessarily a reliance on tradition at the same time as you're trying to inculcate innovation in a system as well. And I think that's a very healthy tension. I mean, it's a highly regulated profession. There's a lot of regulation, a lot of policy around it, and I think that's necessary. And in fact, and we'll probably talk about this a little bit later on, but I mean, when we start talking about some of the dysfunctions in American healthcare, I would argue that a lot of it actually stems from, on one hand, an overregulation of certain things and an underregulation of others. I think we underregulate the payer space, and I think we overregulate the care delivery space. And that's a natural tension that just has to kind of work its way through the system.
Hello, everyone. It's Anne-Marie from the Project Good podcast. Change always starts somewhere. Reach people who care about what you care about. Advertise on the Project Good podcast today by contacting us at projectgood.work/podcast. Yes, and you started getting me thinking about like pharmaceutical companies as well. Mm-hmm. And I've seen this because I grew up with someone in the medical field a lot. So I was at one time I looked at being a physical therapist, but then I realized I didn't really like, not that you encounter that much blood in physical therapy, but then also when I interned, I realized the patients in physical therapy, like they'd be like, I don't want to do the exercises. So I was like, okay, well,
Sure.
why are you here?
Yeah. Yeah.
And so
Yeah.
then I felt that there was nothing, because you can't make somebody move their body physically if they don't want to. So I was like, okay, well, so it wasn't working for me.
Yeah.
But so anyhow, sorry, that was an aside. I just remember that because I would get frustrated. I'd be like, what is the point?
Yeah. 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 Well, that's the holistic approach, right? I mean, you have to, you got to take a perspective onto the whole patient to figure out why they're there and what's wrong. So, yeah.
Yes. And so, so then when as I started off with there's the pharmaceuticals, sometimes, I guess not to be offensive, but sometimes I felt that, that they were, and coming from a marketing background, that, doctors were becoming like marketers and, I guess for some people, the lack of the softer term, a little bit of drug pushers, but marketers for these pharmaceutical companies, because that's, what it goes in, new drugs are introduced, and then, and everybody's like, briefed on, what does this new drug do? And, who should you recommend? And so there becomes, and obviously in some cases, depending on what kind of drug, there's, economic factors that are tied to it. And, when these things are happening, I don't know, I'm sure you've seen this, then the patient gets pushed in the back, because it's like you are you have the doctor, that have your job, then you have, now you have to log everything on a computer. That's the other thing that I see when you go to the doctor's office. It's like, just a minute. I need 30 minutes to like enter it. And then they're like, okay, and what's your problem now?
Yeah. Yeah.
Right? Like, and God forbid that like you make an error on the computer, like, just a moment, I have to go back and delete what I typed. My brain was thinking about a different patient. Right?
Yeah. 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 Sure.
Right. And so, I've watched this. And so, it's kind of in my mind, like, care is non-existent, because you're going through this like long checklist of things you have to do.
Yeah, I mean, you raised two interesting points here. I mean, let's talk about them just quickly in order. I mean, I think the reason doctors are sitting there charting the way they're charting is that the insurance companies require that certain things are put on the chart in order for the doctor to bill for service. And so, like, the doctor doesn't get paid unless he documents, for example, 8 review of systems, and has to document social history and family history. And so the electronic medical records are all set up in order to encourage billing at the highest possible level for the visit that you have. And so there are a series of checkboxes that have to be checked. And if the doctor doesn't check the boxes, the insurance company pushes back, it doesn't pay the bill. And it's become this game between the insurance companies and the doctors. And the victim in all of this, of course, is the patient, who just simply wants 10 or 15 minutes to talk to his or her doctor. And the doctor's sitting there trying to get, even modest reimbursement for the office visit from the insurance companies. And the only way this works is by clicking the boxes again and again. It's ridiculous, right? It's an absolute waste of time. If you take a look actually at medical records in Europe as an example, they're the way we used to write medical records probably 30, 40 years ago. I mean, they are succinct, they're thoughtful, they detail only the pertinent information, they communicate a lot of information. Today, when you get a referral, usually they are just cut and pasted documents that are printed out of the electronic record that go on for pages and pages and pages, and they're filled with utterly meaningless information that does nothing but allow for billing, right? So you've actually sacrificed clinical service in the name of being able to pay. This is this kind of bureaucracy that's crept up around healthcare. And it's toxic. I mean, it's really strangling the system, and patients feel it firsthand. You're absolutely right, Anne-Marie. That's exactly what they notice. The pharmaceutical industry is a whole different kettle of fish. And, this is a tough one, right? Because on one hand, you have these companies that are discovering these extraordinary medications. I'll give you an example. I mean, everybody has heard of the Ozempics and the Wegovy's, right? The GLP-1s. This is an extraordinary class of medicine, right? These are originally diabetes medicines that are now being taken by people for obesity. And we're still early in the game. I mean, I don't know if we fully know how effective these drugs will be over the long term and how safe they are over the long term. But what we are discovering is that patients are losing significant weight. And in many patients, all of their health measures are getting better. Their blood pressure gets better. Their kidney function gets better. The data is very, very supportive of this extraordinary innovation. Now, the downside is the drugs are costing close to $1,000 a month, in some cases more, and many insurance companies don't pay for them. And so you've got this system where in the United States, patients are paying multiples of the European price, multiples of the Canadian price for the identical medication. And the reason the drug companies can charge so much is because the American system allows them to do so. The American system allows them to charge whatever the market will bear, and they do so. And I'm not sure whether you consider that to be ethical or unethical. I consider it to be unethical. And there are other examples clearly of unethical pharmaceutical behavior as well. I mean, one example was the opiate crisis, where we had companies, pharmaceutical companies, aggressively pushing long-acting opiates and getting entire generations addicted to opiates. So these things are sort of double-edged swords, right? You have on one hand extraordinary innovation, extraordinary benefits to patients that we would have never seen years ago, cancer patients being saved by innovations in healthcare. At the same time as we have, pure unadulterated greed and patients being taken advantage of, and it's a complex system.
Yes, and that leads me kind of as you were talking about, just charging whatever prices, because I've seen, of course, the ads and listened to stories where people needed a certain medication to be able to function successfully, and they couldn't afford it. And so, then they started having all these other complications, or in some sad cases died. And so obviously, that's definitely, I would think, unethical. Let somebody die because you can't give them the medicine that is available. I know in different cases, if it's, there's no supplies, well, sadly it is what it is if there's, none in the whole country. But if it is around and then you let people die because you're like, oh, you're $5 short, yeah, definitely that's a red flag and whatever else we want to call it.
Yeah.
And so, obviously, this discussion about healthcare has been a hot topic for years. Obviously, it was the big thing during the election time of Obama, and obviously they have the tag Affordable Care is now has the tag name Obamacare and all this stuff, right? So we know that affordability has been a big question mark and to do, but I guess from a personal aspect, I guess, do you feel that healthcare should be free, or how can we, I guess, or I'm sure you have ideas about how do we make it affordable?
Yeah, I mean, it's funny, actually. Obamacare did a lot to expand access to service, but didn't do a whole lot to decrease the price of care, which was, I think, in retrospect, one of the big problems. It was a huge step forward, but it was not the only work that needed to be done. There's a real price problem, a cost problem in American healthcare that needs to be addressed. I mean, listen, you asked if I think that healthcare should be free. I mean, I believe so. I mean, that's certainly my belief. And I think that most societies, to one extent or another, believe that as well. There's, in one form or another, almost every country in the world makes provisions for healthcare for folks who can't afford it, whether it's providing basic government services free of charge, whether it's, as we do in America, offer Medicaid to patients who are lower income, whether it's charity. I mean, we've got hundreds of years of charitable involvement in healthcare around the world, not just the United States. Here we've got government is the largest payer of healthcare services in the U.S. It takes up 24% of government spending, whether it's the Veterans Administration, whether it's Medicare, whether it's Medicaid. And so every country in the world, I think, at its core believes that we should be providing healthcare to patients across society. How we get there is the question. And this is one of the many tensions that we have in American healthcare, of course.
Yes, and this the affordability. I think, well, yes, I agree that healthcare should be free, but I believe there's too many factors of people wanting money.
Yeah, sure.
And unfortunately, vulnerable people sometimes make the easiest people take advantage of. Um, and so, speaking of sometimes of people and populations that get taken advantage of, in the healthcare system, a lot of times people who are either in ethnic minority groups or sometimes, as I've even read and sometimes shocked, because I was like, oh, is this the same country? Like if people are in really rural areas, they have like no access to anything. I was like, still in this day and age. And so in these, I believe it's kind of its own topic, but we'll just briefly touch on it just because, obviously you went to Africa. And so, you obviously were surrounded by what would be considered the U.S., minority groups. And so in that, I guess, how did that impact you when you came back?
Yeah, what's interesting with Africa is that the main difference that I saw from the United States was that there was just an absolute scarcity of resources in Africa, right? There just wasn't enough to go around. And so the governments did the best they could in many cases to provide basic government services. The clinics, rural county clinics, typically were fairly well stocked and they had basic medication and they could provide basic services. But they just didn't have money for much else. And it was a heavily cash-based economy, frankly, as much of the developing world is, whether it's South America, whether it's Africa, whether it's parts of Asia. Healthcare is generally a cash-based business, and there is really a limit to the complexity of healthcare. I mean, it's a much simpler system of care because people can't afford the most complex services. Here in the United States, we have a different type of problem, which is that there's certainly a lot more resources and the availability of complex care to almost anybody. But the challenge, of course, is that people are bankrupted every day. It's now the leading cause of bankruptcy in the United States. And people have no way, like in Africa, of actually asking the price of anything. I mean, in Africa, at least, there isn't a lot of coverage for healthcare service, but the prices are clearly posted and you know exactly what you're going to pay. And if you can come up with a modest amount of money to pay for your healthcare, you're going to get it. That's just the way it is. I mean, there aren't enough resources to go around. Here, I think it's a bit insidious, right? I think what we do is we're not ever fully transparent about the cost of things. We pass on hyperinflated prices to self-pay patients that we don't pass on to insured patients. And we get people to take the healthcare service without knowing what they're buying and then put them on the hook. In many cases, collections agents are sent out and people are bankrupted. And so it's an insidious and I think quite a immoral way of dealing with things.
Yes. I started thinking about like getting bankrupt for your health, and it just puts you, it's just a spiral down. And so, this is, as the problem, I believe the problem is just going to get bigger and bigger because we have an aging population. And, obvious things with aging, as you get older, you might not be able to work as much. And so then, obviously, if you're not working as much, you can't bring in that income, or maybe you were in retirement, but you didn't expect to live till, 100 or something like that, right? Mm-hmm. And so you're like, okay, well, I've been retired since, 68, but, now I live to 100. And that's a lot of years, even if you saved up, what was quote unquote the proper retirement, you didn't plan for that long of a life, right?
Mm-hmm. Mm-hmm. That's right.
And so, this problem is just compounding. Like, even though it's great, I'm not saying, I don't think anybody's like, I want a short life, right? Mm-hmm. So it's great that we're living longer, but it is adding a lot of complexities to the situation. One of the other things I want to touch on, just because I was recently reading articles. So we already know this is I might sound really bad, but we already know that the youth is in trouble across the board, right?
Sure.
The youth is in trouble. The youth are in trouble because of a lot of different reasons. They've experienced some really traumatic things. They don't necessarily live in the real world. What I mean is they spend most of their time in, virtual time on the computer, and also they're a little bit disillusioned from what I've been reading about, what the future holds, if there's even a future to some of them, right?
Okay. Okay.
And so this is problematic because these are the people that we're supposed to depend on for care.
Yeah. Yeah. No, you're right. I mean, it's a bit discouraging. On one hand, you've got these seniors and you've got this huge demographic problem, right? This rapidly aging population who are living longer than ever, which is terrific, but they're not necessarily living longer in good health, right? I think those are two different things. I mean, you've got a population of people who've had chronic diseases, in many cases poorly managed, who are nevertheless living longer, and placing unprecedented demands on the healthcare system, which is something we're going to have to wrap our head around. At the same time, we just don't have enough formal caregivers in the system. I mean, there's not enough home health aides, there's not enough therapists, there's not enough of any of those kinds of people. So we've got this huge demographic time bomb, and it's not limited to the United States. I mean, this is a huge issue, and Japan is an example, and parts of Europe. I mean, the fertility rate is falling in all of those industrialized countries, and they've got the same demographic problem as we have. But you raise such an interesting question about young people, and what I've been reading and I'm really concerned about, and I think the Surgeon General has really called this out in recent years, is this epidemic of loneliness, not just among seniors, which is a real concern, but there's really an epidemic of loneliness amongst even young people today, where they're not dating, they're not hanging out with friends in real life as they used to. They're not joining clubs. There are few clubs to join anymore, and people don't go to social clubs or do social activities or join churches or whatever sort of community they had developed in past generations doesn't exist today, and people are sort of texting and scrolling on Instagram, and I think it's a very, very hollow existence, and it's really concerning. I think the Surgeon General was quite right to call this out as our big public health crisis.
Yes, and so, one of the things, also is because a lot of, it's not I guess it could be considered dramatic from past, but a lot of things is the youth are not also enrolling in universities and colleges anymore because, they don't see the point in a lot of ways because they're like, well, I can make money doing this and this, or, I don't want to do the traditional route, or once again, there's no future. I guess what would you say to encourage, someone to join the medical field? What would be, what would you say to get people to start jumping into the profession?
Yeah, I mean, I don't necessarily know if I have I don't have a big hang up about people not going to university. I think in some cases, people have been scammed over the years by predatory for-profit universities and colleges that are charging a lot of money and offering really useless degrees, right? And I think there's a lot of value to be had in pursuing, for example, trade schools or community colleges where you come out with a skill. A lot of these programs, you graduate and you're earning very good money very quickly, right? And certainly more than a philosophy and religion major in university, I can tell you. So, I'm not so sure this is a negative pushback. I think this expectation that everybody has to go and get this 4-year degree, there are alternative paths, whether it's the military or whether it's community college, that I think will lead to a very, very fulfilling and well-paying careers for people without the burden of these huge student loans that hang over people. That said, there's a bunch of ways to get into the healthcare professions. I mean, there's such a shortage, whether it's therapists or whether it's registered nurses or LPNs or paramedics, as an example. There's a paramedic crisis now where there just aren't simply enough emergency workers. so it's not just physicians that's the issue. We've got this across the spectrum, and it's sad, right? Because I think there's just such these are great careers. I think they are meaningful careers that deliver very, very important services. And there are careers that aren't going anywhere. I mean, you are not, no matter whether you have a recession or you don't have a recession, whatever the issue is, those are jobs that are not going anywhere. So I would encourage people to really strongly take a look at them wherever, whatever part of the system they're interested in.
I like that approach that, I think one of the things that I think the youth crave, or anybody craves, is stability. So that is a good push that, yes, we're always going to need medical professions because, as long as we have humans on the planet, they're going to get hurt and they're going to get sick. So we definitely need people around. I love that. Push the stability part.
Well, healthcare is one of the largest employers in the United States, certainly in rural areas. If you take a look at rural parts of the United States, the largest employer is inevitably the local hospital. It's a major part of the U.S. economy. We're now up to 17 or 18% of U.S. GDP is spent on healthcare, which is much higher, really, than any other developed country. And that's a good thing and a bad thing. I mean, on one level, it's a bad thing because we're spending a lot of money on overpriced healthcare services. But on the other, it means that more people are getting service, more people are getting covered, and that we're able to deliver high-tech healthcare services. And so it's not necessarily a bad thing that it's so high, but if you want to talk about opportunity, yeah, this is a major, major part of our healthcare, of our economic space, healthcare, and it's a great opportunity for people to get a stable and well-paying career.
Yes, and now I'm going to ask you the opposite question. What advice would you give to other medical professionals experiencing burnout in their careers?
It's such an issue. I mean, I think we're dealing with burnout both amongst physicians and amongst nurses. Burnout, technically is described as three things. One, it's an emotional exhaustion. The second, it's this sense of depersonalization. So these are people who lack empathy or have negative attitudes towards patients. And then the third is this feeling that you haven't really achieved anything, that you've got this decreased sense of personal achievement. And that's really the definition of physician burnout. And oftentimes people say, well, yeah, the doctor's burned out because, something to do with the doctor not being resilient enough or whatever. I think what we've learned through a number of years of research into this is that ultimately it's about a broken healthcare system. People aren't leaving their careers, they're leaving their inboxes. That there has been such a burden placed upon nurses and doctors and healthcare workers to document, to chart, to fill out forms, to answer text messages, burden after burden after burden after burden that just never seems to get reduced, no matter how hard you work. And it leads to the cynicism and people leaving the profession in droves. There's nothing wrong with medicine, right? Medicine is as worthy a profession as it was when I first started as a student years and years ago. But what's happened is that the system, for various reasons, has become more bureaucratic and more onerous. And all of the burden seems to rest at the feet of the clinicians, right? The administrators grow in number and scope. The regulations grow in number and scope. The insurance companies grow in number and scope. And all of the requirements are pushed down to the poor clinicians who are at the front line of this whole thing. And the people who feel it are, of course, the patients. So you've got this sort of whole system of insurance companies and bureaucracy and payers and form filers and claims processors. This is massive, massive industry that all kind of revolves around this core thing, which is the doctor-patient relationship. It's the most sacred and most important thing, and it's the one that's constantly being imposed upon.
The instant thing I thought is that as individual humans, we don't really own our bodies. When you started talking about all the, I started seeing like an org chart, right? Mm-hmm. And the most important thing, the goal is to, make the patient better, or it should be, right? But all of that is lost, and you think it's I now it makes it clear then why people kind of have freak out moments when they have to go into a hospital for something major, because it's like you're handing over, your body to these people, and you really have no control about, what's going to happen to it, even though it's your own body, right?
Easy.
Because there's so many pieces that are pulling on it. It could be, everything from, you have drug companies, then it's like, okay, well, this is not how the rules are. If you want to, if this person says, instead of, doing my medication today, I want to just go and sit on the beach and look at the water. No, can't happen. Then, there's like, have you filled out your 29 pages of paperwork? And then there's the, that's not how it's done here.
Sure.
So it's heavy, and the goal of getting better, it just gets lost.
Yeah. Yeah, you feel like, you're there to sort of have this intimate relationship with your care team, and ultimately you're accountable to this big system instead, right? That's kind of sucking in your data and trying to monetize your healthcare, and it's an icky feeling. I get it.
Yes. And so I guess if you wanted to do, I know it's hard to do blanket statements, but I'm just for time's sake, if you had to, for the current healthcare, different companies and things like that, what would you, if you had to give them a line of how can they start to change, or what do they need to, how do they have to rethink if they really want to start making differences with the actual patients that were the goal?
Yeah, I mean, we've got to strip away the superfluous stuff, the nonsense, and I think the way that we do that is that the way that we pay for healthcare has to be fundamentally changed. We pay for healthcare in the United States using a concept called fee for service, and so basically, when you receive a service from a doctor or from a hospital, that individual service is documented and submitted to the insurance company for payments, and the more services that are delivered, or consultations that are done, or surgeries that are performed, or widgets that are delivered, the more that's paid. And so it's basically paid per volume. And that's a very toxic way of paying for healthcare, because what it incentivizes is more volume, even for patients who don't necessarily need more volume, but may need something, as we talked about before, more counseling or an intervention to take them shopping, things that are not paid for by the healthcare system, but would be very effective. And so there's two things that need to change. One is we've got to get away from this fee-for-service system. The system will never be fixed so long as it's paid for fee-for-service. I've seen this now for the years and decades I've been in healthcare. There is no way to do this well, fee-for-service. So people have looked at this for years. There are concepts called alternative payment models. That's I guess a different story for a different day, and we can talk about those. But that's number one. Number two is there is, on some level, healthcare is not a purely capitalistic initiative, right? There have to be brakes on the healthcare system, and those brakes are necessarily regulation and policy. Like, I'm no big fan of regulation and policy, but there needs to be intervention in order to set the standard and to keep the system in check. Otherwise, what you get is this healthcare capitalism on steroids that takes advantage of people and creates completely the wrong incentives in the system. And so I've come to terms with the fact that there's no substitute for an effective regulator in this space, unfortunately.
Mm-hmm. And so now I want to have a little bit of fun, because we've hit a lot of heavy things.
Yes, it is heavy, Henry.
They have a lot of heavy things, and
yeah.
I was just thinking, I'm like, I was thinking I have to make sure I'm doing all the right healthy things. And, when I have to get into like a real situation, hopefully I'm old enough that I'm like, okay, whatever, throw the dice.
Yeah.
Yes. Yeah. And so I wanted to just ask a fun question. because, like I said, I like adventure. I wanted to know what was the thing that scared you the most when you decided to join the AMREF flying doctors?
Yes. So, flying in Africa is not necessarily for the faint of heart, right? There are a few lit runways. There were a lot of landings that took place on remote dirt strips with wild animals running around. There were corrupt governments taking bribes. There were a lot of armed folks, different insurgency groups, and there were times that we flew into frank war zones, such as Somalia, to rescue patients. And so I had very practical concerns, which was that I didn't want to be shot or hurt or a victim of a plane crash. And so, those are maybe my sort of selfish concerns about flying there. But I will say that I was really well taken care of by the folks at AMREF. They just a superb organization and have such street smarts from having done it for so many years that I never felt really that I was in severe risk after I got to meet these people and saw how they did business.
Understandable. Yeah. If you wouldn't want to become a patient yourself.
That's right. Yeah.
Yes. And I have only two more questions and then we'll wrap it up. Mm-hmm. What one thing do you want people to learn from reading your book?
I was very impressed in the book. I wrote a little bit about the founding of AMREF. It was an organization that came together by three physicians back in the early 1950s. One was an American surgeon, plastic surgeon called Tom Rees, and then there were two English surgeons. One was the chief surgeon of the Royal Air Force after World War II. And really, these three founded this organization that today has grown into really the largest healthcare non-governmental organization in Africa. They do incredible work across the continent, everything from public health and hand washing and water sanitation, all the way through air medical evacuation. And what I was most impressed by was how a handful of people, two or three people, can, just through diligence and hard work and motivation, create an organization that now, 70 years later, is still going strong and doing extraordinary work that has just kind of dramatically magnified the efforts of the first three people a couple of years later. And so I think really what impressed me most about it and what I hope people take away from the book is that it just takes a spark of a few people to set a vision and to put their heads down and to get the work done. And the ripple effects from that are so enormous. And just to encourage people to take the step to build something, even if it seems modest at the beginning, with the hopes that it turns into something as extraordinary as AMREF.
I love that. And that's, definitely motivation for the healthcare system as well, that it only takes, a few innovators to be listened to and for people to start moving. Mm-hmm. And then this is my last question. If you had to redo your life, would you choose to be a doctor again?
Oh, sure. I mean, I'd love being a doctor. Listen, I haven't actually, ever been a doctor in the most traditional sense of hanging out a shingle and seeing patients. I've had this most extraordinary and interesting career that's bounced between seeing patients in an ER and being in the international setting and working in international health systems and doing administration, and now most recently entering a new specialty of hospice and palliative care medicine. It's never been boring, and it's been the most intellectually satisfying career I could have imagined. And I'm delighted I made that decision in college to pursue medicine because it turned out to have been just the perfect fit.
Wonderful. Well, I really enjoyed our conversation today. And thank you, Dr. Monk, for your time and insight.
It's been my pleasure.
Yes, so thank you, Dr. Monk, for your time and insight. If you'd like to learn more about Dr. Monk and his book, go to mdmonk.com. If you have a passion for an unserved community, a social justice problem, or simply want to change minds, contact Project Good Work at projectgood.work to start your project of change today. It's that time again. The Changemaker Conference is happening September 12th. Register now to attend for free at changemakerconference.com. To our listeners, thanks for tuning in to Project Good, where we're focused on what matters.